gradual development of generalized weakness, lassitude, drowsiness, and ultimately the patient died. So what's happening? Then they look at their all the patients who underwent total thyroidectomy, and then they realize that there is something that is secreted from the thyroid gland which is essential for life. And then comes the conception of hypothyroidism. This is one of the photograph from the archive, the patient with this condition after thyroidectomy, few months after that. So cachexia stummipriva. So if we discuss hypothyroidism, it is very important to note the pathophysiology of this condition. And before that, you need to know a bit of physiology. So typically, you know, the TRH, which is secreted from hypothalamus, it stimulates pituitary to secrete TSH, which acts on thyroid gland to secrete T4 as well as T3. And this T4, it goes to periphery, and in different cells, again it's converted to T3 and exerts its action. Not only that, these thyroid hormones, they exert their feedback inhibition on both pituitary and hypothalamus. So when we discuss various conditions associated with hypothyroidism, this feedback loop is extremely important to understand. And this TRH and TSH has some additional action as well. So we'll discuss those while we discuss different cases. So how to classify this condition? Depending on time of onset, it can be classified as congenital or acquired, of course when it developed. Depending on the organ that is primarily affected, it can be called primary when the thyroid gland is affected, or secondary when hypothalamus or pituitary is at fault. Or according to severity, it can be called overt when the clinical features are apparent, and mild, that is subclinical, defined both clinically as well as by biochemical markers. So if we look at different causes of hypothyroidism, there are many causes. I won't go into detail of all these, but primary hypothyroid, there are two major causes. Number one, autoimmune, and number two, iodine deficiency. Whereas in central hypothyroidism, the major cause is dysfunction or some organic lesion in pituitary and or hypothalamus. So what is the clinical manifestation of hypothyroidism? Typically, the patient can present with cold intolerance. There is a very common idea that obesity, and many of your patients also will also tell you that my TSH is 9.1 and that's why I am becoming obese. Even after treatment of levothyroxine taking for so many years, I am gradually becoming obese. That is not so. Even with frank, overt hypothyroidism, weight gain is not more than 10%. So beyond that, it's unlikely due to primary hypothyroidism. Look for other causes. In children and adolescents, impaired growth is extremely important, and dyslipidemia is very common. So whenever you get a patient with very high LDL cholesterol and triglyceride, before starting statin, please look at the patient clinically. If need, do a thyroid function test. Do not start statin, because in presence of overt hypothyroidism, statin can cause severe intolerance, including myopathy. Okay, so be a bit careful regarding this. Regarding skin and appendages, the skin looks dry, pale, it will be thick. There can be yellowish discoloration of palms and soles. Hair may feel dull, coarse, and there can be brittleness, and there can be diffuse hair loss. However, there can be increase in lanugo hairs, okay? The thin, fine vellus hairs, particularly over the back. And the nails can also become a bit brittle and grooved. Nervous system is one of the systems that is very commonly affected. Typically, the movement, thought, everything gets slows down. So it's kind of the patient like appears that he or she is in a slow motion, right? So the way they talk, the way they think even, everything slows down. And there can be drowsiness, depression, even ataxia, various neuropathies and carpal tunnel syndrome. So all of these can be present in one patient or in different patients. Among musculoskeletal system, myalgia, muscle weakness, stiffness are very common. There can be myotonia as well. Okay, that can be a feature of hypothyroidism. Delayed relaxation of ankle jerk is a very important sign to us. When there is a biochemical pictures may not be that clear, sometimes we rely upon this test. And sometimes there can be pseudo hypertrophy of muscles. And there can be some joint stiffness and arthralgia. In cardiovascular system, there can be increase in diastolic blood pressure, and systolic blood pressure is typically reduced. And sometimes there can be pericardial effusion. Bradycardia, of course, is a feature. And primarily because of dyslipidemia and due to other factors, increased incidence of IHD, ischemic heart disease, is also seen in hypothyroidism. Respiratory system is rarely affected, but some patient may complain of shortness of breath. Reproductive system is again another system which is affected pretty commonly. Okay, so in pubertal age there can be delayed puberty, there can be gonadotropin independent isosexual precocity in females, which is very rare. I will discuss one of the cases. There can be oligomenorrhea and menorrhagia. Again, it's a very common manifestation. There can be galactorrhea. Why? Anyone? Quick take. Why there should be galactorrhea in primary hypothyroidism? Again, very important take that even if there is galactorrhea and prolactin is high, do not start cabergoline. Okay, look for cause. That's what we repeatedly tell our gynecology friends. So, okay. As I was discussing the feedback mechanisms in primary hypothyroidism, the T4 is low, therefore TRH is very high, and TRH is most important stimulator of prolactin secretion. Okay? So that's why there is hyperprolactinemia and there can be galactorrhea. Subfertility is very, very common, and many pregnancy-related complications can occur. Gastrointestinal system, constipation is very common, particularly in children. Constipation is possibly the feature. It's very commonly reported by parents. Very rarely malabsorption can be there. Either it can be due to small intestinal bacterial overgrowth because of slow transit time, or as primary hypothyroidism is most commonly due to autoimmune thyroiditis, so associated autoimmune conditions like celiac disease or pernicious anemia can be there, which can lead to malabsorptions. Anemia is very common. So anemia can be normochromic normocytic, which is a typical feature of hypothyroidism. However, there can be menorrhagia, as I have said, which is very common, that can lead to iron deficiency and microcytic hypochromic anemia. And due to autoimmune association, pernicious anemia can be there. So there can be macrocytic anemia rarely as well. There can be bleeding diathesis. Okay, it's a somewhat akin to von Willebrand syndrome. So mainly there can be platelet dysfunctions, which is entirely correctable by giving levothyroxine supplement. So before going into case, let's just reiterate that whatever we have talked about in children, adolescents and adults, do not forget neonates. So as many of you are in general practice, please convince your gynae colleagues, your relatives and your pediatricians that all neonates, at least 72 hours after birth, should undergo a thyroid function test. This is a must, because congenital hypothyroidism is the commonest cause of reversible permanent mental disability. Okay? It's very common, 1 in 1200 approximately, often missed, and unless treated very rapidly on an emergent basis, particularly in the first 3 years of life, it can lead to permanent mental impairment throughout their life. So please remember this and practice this and propagate this. So going back to the cases after this background informations. So we are talking about this patient, 49-year-old male recovered from COVID. So this is a typical case of recovery from sick euthyroid syndrome. So if you look at the pictures of sick euthyroid, so mild, moderate and severe are here, and in the last you can say recovery. Okay? So recovery, you can see the free T4 can be low but typically normal, and TSH is high. So what to do in this patient? Just wait. Wait for around say 6 weeks or so. Then recheck thyroid function. more often than not, the thyroid function will become normal. But if not, then we treat accordingly. Okay? The second patient, amenorrhea for 7 years with weakness, hyponatremia, slightly high TSH and clearly low FT4. So what's happening here? So here another important catch. Please remember, if T4 is clearly low and TSH is normal or slightly high, this can be due to central hypothyroidism. Because whenever in a patient who is overtly hypothyroid, there is clear demonstration of low T4 level, but TSH is not very high, because with every unit of reduction of free T4, there should be around 100 times increase in TSH. So if TSH is not that high, always think about that whether you are dealing with central hypothyroidism or not. It's very important to identify, because if you start levothyroxine by seeing the TSH level, again a very important note here. It's a very common practice that starting a TSH level of 10, 12, 15, starting a levothyroxine then and there. Please do not do it. We have seen patients landing up with catastrophic outcome. Please test T4, then and then only start treatment, okay? So unless you are sure you are not dealing with primary hypothyroidism, do not start treatment with levothyroxine. That can be catastrophic. Why? Because in these patients with central hypothyroidism, there can be associated central adrenocortical insufficiency as well. Once you start with levothyroxine, it will accelerate the metabolism and patient lands up with adrenal crisis. And that can be devastating. Unless diagnosed and treated very promptly, it is life-threatening. So please remember, do not start levothyroxine just after seeing a TSH level of 10, 12, 15. Please remember this. So in this particular patient, we suspected central hypothyroidism. There was cortisol deficiency as well. And what we did, then we did a pituitary MRI. And you can see the pituitary tumor sitting there. So that is causing panhypopituitarism. And that actually led to amenorrhea. So again, secondary amenorrhea is a very important condition you need to evaluate before starting treatment. So secondary amenorrhea, slightly high TSH, high prolactin, do not start treatment automatically. These are the situations where you should and must go deep down, diagnose the patient first, and then only start treatment. The 27-year-old man with generalized weakness, slightly high TSH, PT4 was normal, and if you remember the picture, we identified the condition correctly. This is Addison's disease or primary adrenal insufficiency. Now, in this situation, due to adrenal insufficiency itself, there can be slight elevation of TSH. Or, if it is an autoimmune condition, just due to autoimmune association, there can be primary adrenalitis leading to primary adrenocortical insufficiency. So, whatever the case, start treatment for adrenal insufficiency first, and then if needed, you can start levothyroxine. But in a patient like this, where TSH is slightly high, you should wait and watch for 6 weeks to 8 weeks, recheck thyroid function after replacement of glucocorticoid and if needed mineralocorticoid, recheck the thyroid function. If it is still high, then decide about starting treatment. Okay? So, after these cases, let's discuss few of the less common presentation, okay? The situations I have discussed till now were pretty common things. Now we'll discuss some interesting cases, some rare cases. I will show you just a clinical outline and few pictures rapidly, okay? This is a 13-year-old girl, severe primary hypothyroidism, okay? Severe short stature, should have been diagnosed years ago, but missed. And you see there is no pubertal development, typical myxedematous feature. And if you look at the cuff, what is that? In cuff, I have already discussed this condition. I said there can be pseudo-hypertrophy, okay? May not be very apparent over here, but pseudo-hypertrophy can be there. It's called Hoffman syndrome. And I was discussing lanugo hair. The lanugo hair is there in the back. Once you start treatments, these hairs will go off. This 25-year-old lady, okay, no pubertal development, severe short stature, gross myxedematous feature. It's very unfortunate. In our country, we get patients like this. And even at this age, even at the age of 25 years, when we started levothyroxine, Although there is no significant height gain, but at least pubertal development was there. So you can well imagine if we started treatment properly in right time, there would be a huge improvement in clinical situation. This is the other end of the spectrum. This 7.5-year-old girl developed breast budding at the age of 6.5 years, okay? And now this is the breast age. This is the other end of the spectrum. This is the biochemical picture. There is severe primary hypothyroidism due to Hashimoto's thyroiditis. Antithyroid antibody or anti-TPO is very high. But there is also high FSH and very high estradiol. So what's happening here? High level of, again, here it's called a specificity spillover. What is that? Very high level of TRH, again acting on gonadotropes, secreting excess FSH. And very high TSH acting on ovaries, where it can cause stimulation of ovaries via FSH receptor. So there is specificity spillover in 2 different levels, leading to hyperestrogenemia with development of precocious puberty. This is called Van Wijk-Grambach syndrome. This is the ovaries here, large, hugely cystic ovaries. Huh? So, but if you do a bone age, unless other causes of precocious puberty, the bone age is not advanced, rather it is delayed. Pituitary shows a big mass. What is that? Why there is a mass in pituitary? Tumor? No. This is the proliferation of thyrotropes due to excess TRH. So if you treat over the years, it should regress. So we reported this patient. Okay, so you all know that in central hypothyroidism, typical myxedematous features are not there. However, in severe central hypothyroidism, these typical myxedematous features can be there. So this patient, although having all the features of myxedema, actually the feature is suggestive of central hypothyroidism. Okay, the total T4 is very low. And MRI shows empty sella. So this is a patient with acromegaly, right? This is my hand, and this is the hand of the patient. Typically enlarged hands, and you can see the facial appearance as well. There is a pituitary tumor causing acromegaly. No. This is a situation known as pseudoacromegaly. And primary hypothyroidism is one of the causes of pseudoacromegaly. This pituitary enlargement is due to hyperplasia of thyrotrope, just like our previous case. Okay? And the facial and hand appearance are due to myxedema. So we reported this case in BMJ. Sometimes we know that typical pericardial effusion in hypothyroidism does not cause tamponade, but rarely it can, like in this particular patient. This is a case of, please, we need more interaction, please. Graves, right. Why Graves? Because there is prominence of eyes, right? But this is the thyroid function. What is that? This is a primary hypothyroidism. So please remember, the Graves' orbitopathy can be there in primary hypothyroidism as well. And this TRAB is very high. This thyroid receptor antibody is very high, which is acting on the orbital muscles causing proptosis. So typically it occurs along with thyrotoxicosis, but sometimes it can occur in euthyroid as well as hypothyroid individual when TRAB level is high. 4-year-old girl, constipation and dysphagia. What is that? There is a mass in the pharynx, oropharynx here. This is the uptake scan, only uptake in this particular region, in the base of the tongue. This is called lingual thyroid. Okay? So you treat with thyroxine, many a times it can regress. And dysphagia and constipation both disappeared. Constipation was due to hypothyroidism, which is very common in ectopic thyroid. So to summarize, hypothyroidism is a very, very common endocrine disorder. Presentation can be varied, widely varied presentation as I have discussed. But suspicion is a very important key. Testing is usually straightforward, but you have to be careful about the interpretation. Treatment is again usually straightforward with levothyroxine. But again, you need to be careful in certain situation, and thorough clinical examination is important to rule out mimics. So I will end here. Thank you for being patient listener.
Thank you, Rana, for your excellent deliberation, case-based discussion in a very interesting way. I think audience have learned a lot from this, so please be seated here, and I will hand over my microphone to my co-chairperson.
So thank you, Ranada. So please have a seat. Just I have a question, Ranada. So should I repeat the TSH after the sick-youth-heart syndrome? Every
Yes.
patient?
In sick-youth-heart syndrome, it's better to wait and watch. You wait for 6 weeks post-recovery, and then you recheck. It's a very important step. Otherwise, it's very difficult to diagnose at that stage, when patient is recovering from a sick-youth-heart stage.
Okay. And second question is that we have seen that many patients, not many patients, few patients, they have, despite getting the higher dose of levothyroxine, still we are difficult to manage the TSH level. So what do you think, what were the factors?
Right. I had many of those cases, but again, due to paucity of time, I did not include the therapeutic part. So there can be many reasons. So please remember, whenever a patient is getting an unusually high dose of levothyroxine, please take thorough history, clinical examination, and do appropriate tests if needed. Okay? So the commonest cause of this, the patient requiring very high dose, still not getting control, is non-compliance. I think it's the most important cause. You have to ask patient many a times, how is he taking thyroid tablet, what kind of tablet he is taking, how he is preserving the tablet, all those details. And then if you are sure that the compliance is okay, then you look at the other factors, like whether they are taking other medicines, so which can interfere with the levothyroxine absorption. Or there are some other conditions like nephrotic syndrome, which can lead to excretion of thyroid binding globulin, which increases the requirement of thyroid hormones. And there are many, many causes, and we have many cases of these things of very...
okay, so please come and sit here.
Okay, thank
you. So now the next topic will be discussed by Subhankar sir. Actually, sir does not need any introduction. So sir will teach us the hyperthyroidism topic. So I think everyone will be benefited by sir's talk. So over to sir.
Thank you very much. A very good afternoon. So what I'll try and do is primarily look at the diagnostic part, maybe try and touch the treatment part. Do we have a timer somewhere? There, okay, yeah. So how do you diagnose hyperthyroidism is the topic that's given to me. Low TSH, are you all agreed? Low TSH is what we start with? Yes or no? Yes. There will be very rare instances where high TSH can cause hyperthyroidism if the pituitary gland, there is a tumor which produces TSH, which stimulates the thyroid. But for practical purposes, we start with low TSH. But if you, is that sufficient to make a diagnosis of hyperthyroidism? Anyone please? Yes? No. Why no? Yeah, sorry? Right, yeah, so with a low TSH, you can either have something that Dr. Rana Bhattacharya has referred to, low T3, low T4 or free T4 because of central hypothyroidism. But the TSH is low. So if you, on the basis of TSH being low, if you start on treatment for hypothyroidism, we'll be on the wrong path. And then if you have T3 elevated and free T4 or T4 elevated, then what is the diagnosis? The diagnosis will be that there is excess thyroid hormones in circulation, which is suppressing the TSH. Right? So what do we do with this? If we have got this now satisfied, T3, T4 high, TSH is suppressed. Do we start with antithyroid drugs? Any opinion? Yes or no? Do we start with antithyroid drugs based on this? We have elevated T3, elevated free T4, and a suppressed TSH. Localize the cause. So what could be the cause? most of the time the cause would be in the thyroid itself, most of the time, right? But so what we are trying to drive at is, so this suggests that there is excess thyroid hormones in circulation for which we have multiple causes. Now, why did I bring this up? We are not dermatologists. I'm not a dermatologist, don't know a lot about it, but healthy hair. So this is, I took from the web yesterday only. So, and this costs only 1,099. You get a discount of 200 rupees. So these are there all around. So whether the dermatologist has prescribed or the patient may be taking on his or her own because of hair loss. For better hair, strengthens brittle nails, reduces hair fall. So everyone has, I have a problem of hair fall. So, but I have not taken it. But so why does this question come in? We don't have any conflicts with dermatologists or with people who treat hair fall. Just a second. Because many of these have large amounts of biotin. And because the way we measure these hormones these days, chemiluminescence, which is the best, practically the best method available, their biotin is a component of the assay process. So if you have excess biotin coming from outside, that can affect the assay of the hormones. And so it can give you a biochemical thyrotoxicosis, which is nothing to do with the body. So we need to make sure that the clinical symptom signs also fit in with the blood reports. Most of the time, we should try and match the two. So, yes, so in biotin interference, and when we diagnose hyperthyroidism, the most common cause being Graves' disease because of antibody-mediated process. This antibody is called TSH receptor stimulating antibody, okay? TRAB in short. So if you have excess biotin in your circulation, not only can you get a low TSH, you can have a high T3, high free T4, and even an elevated antibody level. So all of these will fit in with the diagnosis of Graves' disease. But we don't start treatment for Graves' disease just with that. So that once again, it's so important that we do not just go by the biochemical reports, we also need to evaluate the patient as a whole. However, the levels that we are talking of, so many people are on multivitamin, multimineral supplements. Most of them, however, contain relatively small amounts, 40 micrograms of biotin, maybe up to 100 micrograms. But the special hair formula medicines usually have 10 milligrams or above. In the West, for multiple sclerosis, high doses of biotin have shown some results. And so people are on high doses of biotin. There the interference is likely to be more, but even in our country, with the doses roughly 10 milligrams and above, I think there can be interference in your assay. So what do we do? Well, the answer is simple, because biotin is a water-soluble vitamin. So if you stop for 2 days, 3 days, usually the effect would be gone and you reassay, right? So that's the first point. So thyrotoxicosis or hyperthyroidism has to be a clinical diagnosis, not just a biochemical one. And here we have listed the causes of thyrotoxicosis, meaning excess T3, T4, and suppressed TSH. So on the left are conditions where the thyroid gland itself is overactive, is actively producing more hormones. On the right are conditions where the thyroid is the source of the excess hormones in the upper two, but they are not overactive. The thyroid is inflamed, and so there is hormone leaking out from the thyroid gland, and hence the blood levels are high. And then, of course, one could be on exogenous thyroid hormone replacement. So again, the history not only related various other drugs, including thyroxine. Struma ovarii is a rare condition and ovarian tumor where the ovaries harbor a